Great. Thanks so much, Dan. Good evening, everyone. We are very glad to have you all join us this evening for another one of our monthly educational webinars as part of our ongoing educational event offerings here at Genomind through our Genomind 360, the Mental Health Learning Center. Tonight, we're going to be diving into, as Dr. Dowd mentioned, pharmacogenetic considerations for treatment of the geriatric population. As Dan mentioned, my name is Heather Desiderio, and I'm a Senior Clinical Account Executive here at Genomind, and I'm very excited to have the opportunity to welcome you all to tonight's educational webinar. I joined Genomind back in 2017 and have since been fortunate to partner with clinicians across the country in various capacities. Currently, I'm located in the Southeast, supporting both North and South Carolina. For those of you that aren't as familiar with Genomind, Genomind was founded back in 2009 by a psychiatrist and a neurologist. These clinicians saw a need for better mental health care and wanted to create a platform of services to help healthcare providers such as yourselves, patients and employers be better served. So our mission here at Genomind essentially is to lead the evolution of mental health care by partnering with some of the world's leading experts and providers to provide the most progressive and effective tools and services to help improve patients' lives. So Dan, if you don't mind, we'll jump into our next slide here to talk a little bit about you. So tonight's presenter, as some of you may already be very familiar with, is Genomind's very own infamous Dr. Daniel Dowd. So Dr. Dowd is a member of Genomind's executive team, and he currently leads our medical affairs team. He is a PharmD by background, and prior to joining Genomind, he has spent many years both as an educator and a practicing pharmacist. Not only does he lead our respective medical affairs team, but he's also a key lead in Genomind's product development. He is also a member of CPIC. If he looks familiar and you're wondering if you've seen him before, it's true. You may just have seen him on TV because he has been interviewed on numerous national media outlets. So without further ado, we'll get started, and I will turn it over to Dr. Dowd for tonight's presentation.
Okay, thank you, Heather. Heather's going to stay tuned. So if at the end we have questions related to billing or logistical matters regarding the test, Heather will be here to answer those questions. But the primary focus tonight will be clinical considerations for our test, specifically in a geriatric population, or as the American Geriatric Society tends to use the term, older adults. So I'll try to use the term older adults tonight. So the main reason that we're presenting on pharmacogenetics in a geriatric population is because we routinely receive lots of questions about how your genetics changes or how your drug metabolism changes as you age, and how do we incorporate that information with a genetic profile. And so we hope to answer some of those questions tonight. And then also to make everyone aware that Medicare recently launched a coverage policy on pharmacogenetic testing. And obviously, when we're talking about Medicare, we're talking about an older population, 65 and older for the most part. And so pharmacogenetic testing is considered a covered test as long as certain criteria is met. And we'll talk more about that. But again, the focus tonight will largely be on clinical parameters. Here's our agenda for tonight. We'll do a brief introduction of Pharmacokinetics 101. How do your genes affect your exposure to certain medications, and what do you do about that? Then we'll dive into some specifics about geriatric pharmacology. What additional parameters do you need to be concerned about in older adults? And then we'll introduce you briefly to our pharmacogenetic test, which is called Genomind Professional PGx. And then introduce you or reintroduce you to some software that we've built that supplements our pharmacogenetic test, and that's known as GenMed Pro. And we'll try to do all that in 45 minutes so that we have 15 minutes for Q&A. Speaking of Q&A, if you just joined us, there is a Q&A button at the bottom of your screen. We cannot see you, we cannot hear you. This is the webinar version of Zoom, so if you need to communicate with us or ask questions, please use that Q&A function. All right, so let's talk about Pharmacokinetics 101. This is the first thing they teach you in the first day of pharmacy school. They drill into your head the acronym ADME, ADME, and that stands for absorption, distribution, metabolism, and excretion. Okay, and you can see all these parameters listed here, and you can think of this as the life cycle of a drug throughout the body. So almost every drug needs to get absorbed to get into your body. Once it's in your body, it needs to be distributed to the site of action. It usually does that via the blood. After it has reached the site of action and performed its duty, we don't want that drug to exist in our bodies forever. So it usually needs to be metabolized before we can successfully excrete it. And that's it. That's drug in and drug out of your body. Those are the only parameters that occur when it comes to pharmacokinetics. Tonight, we will focus on two aspects of pharmacokinetics. It's the absorption phase and it's the metabolism phase. We're singling those two out because your genetics can influence both of these phases. You can have certain genetic profiles that increases your absorption of psychoactive substances. And then the way we metabolize drugs is extremely variable, and your genetics has a lot to do with that. So we will be focusing on absorption and metabolism, the blue highlighted parameters here. Let's talk a little bit about absorption. I need everyone to be familiar with the concept of P-glycoprotein and drug efflux pumps, because we will talk about a gene that impacts drug efflux pumps, specifically P-glycoprotein. So what do we mean by that? Most drugs, almost every drug that gets into your body needs to be absorbed. Most of our medications are oral, and so most medications are absorbed in the intestine. Now, your body has developed this system to prevent toxins from being absorbed into your body. And that system is called PGP, or P-glycoprotein. Okay, we'll use those terms interchangeably, PGP, P-glycoprotein. And you can see P-glycoprotein is strategically placed all around these important areas of the body. So your brain is surrounded by PGP, your liver, your intestines. If you're a male, your testes. If you're a female, the placenta and the ovaries. So all the important organs are surrounded by PGP. And the purpose of PGP is to prevent things from being absorbed into your circulation, or to prevent things from getting absorbed into your brain. So if we look at this panel to the far right here, think of this as the blood-brain barrier, okay? And right smack in the middle, that protein is a P-glycoprotein. The triangle, the black triangle, that's a drug. Let's call it paroxetine for now, okay? So what normally happens is paroxetine can cross the blood-brain barrier, and then PGP grabs paroxetine and throws it back out of the brain. It is a drug efflux pump. As far as your body is concerned, paroxetine is a toxin. So it takes that toxin and it spits it right back out after it crosses the blood-brain barrier. Okay, it's an important component to protect our brain and protect our body from absorbing toxic substances. Not every drug is sensitive to PGP, but many drugs are. Paroxetine is, venlafaxine is, escitalopram is, aripiprazole is, codeine and morphine are sensitive to it. So there's quite a few psychoactive drugs that are sensitive to P-glycoprotein. And the reason it's important to understand this concept is because some of us make a genetic version of PGP that is deficient, okay? And if we have a deficient version of this pump, we absorb things more rapidly, okay? Certain drugs get into our brain more efficiently if we have a certain genetic variant, okay? We test for that variant. Now, the gene itself is called ABCB1, but that gene, ABCB1, produces P-glycoproteins. Some of us make a wimpy version of that gene, and we have increased blood-brain barrier penetration for certain drugs. So that's absorption, genes related to drug absorption. Okay, we are probably more familiar with genes related to drug metabolism. Now, there are two phases of drug metabolism, and we label these as phase 1 and phase 2. Phase 1 is, think of phase 1 as the big sister and phase 2 as the little sister. So phase 1 is the stronger phase. It does more of the heavy lifting. And the enzymes that we usually think of when we think of phase 1 are things called CYP450. You are probably familiar with CYP2D6, CYP3A4, CYP2C19. These are all CYP450 enzymes that metabolize medications. And when you have deficiency in certain genes, certain enzymes, you can see tremendous variability in the blood levels of these medications. Phase 2 has less of an impact on drug exposure, but it can still have a significant impact. Phase 1 tends to make drugs more water soluble, and then phase 2 increases that water solubility and usually inactivates the drug. It inactivates the drug by attaching this big bulky side chain to the drug. One of those processes is called conjugation. Why am I telling you about phase 2? Because one of the genes, or two of the genes we looked at are called UGT genes, UGT1A4 and UGT2B15. These are two phase 2 enzymes that impact conjugation. And if these enzymes are deficient or abnormal, you can have variability in the blood levels of certain drugs, like lamotrigine, like lorazepam, and some other benzodiazepines. Okay, so that's drug metabolism. Tremendous variability in our ability to metabolize certain medications. Here's sort of the executive summary of all this. P-glycoprotein. So we look at a gene called ABCB1, and this gene makes P-glycoprotein. And what we'll say on our report is, if you have the wimpy version of this gene, you are likely to have greater blood-brain barrier penetration of certain drugs. And that's important to us because our sweet spot is psychiatry and mental health and behavioral health, psychoactive medications. So we are particularly interested in psychoactive substances that need to cross the blood-brain barrier to have their effect. When we talk about phase 1 metabolism, we look at 6 different genes related to phase 1 drug metabolism: CYP1A2, 2B6, 2C9, 2C19, 2D6, and then 3A4/5. 3A4/5, they're like 3A4 and 3A5 are like twins. They both metabolize the same types of medications, so we usually just lump them together. And then our phase 2 enzymes include UGT1A4, UGT2B15. 1A4 breaks down lamotrigine, 2B15 breaks down lorazepam, and some other benzos. All right, so the whole purpose of taking pharmacogenetics into account is to try to make a personalized assessment of an individual's drug exposure. How much medication do we expect this person to be exposed to with standard doses? All right, does a standard dose produce a standard response because they have a standard blood level? Well, there's tremendous variability because of the different phenotypes that people possess. What you see here is a drug versus time concentration curve. The second day of pharmacy school, they teach you about the therapeutic window. That is the ideal drug concentration that you want to maintain any medication in, the therapeutic window. You can see it highlighted by the parallel bars right here. And so what this chart is showing us here is that most people are normal metabolizers. They are also called, sometimes called extensive metabolizers, but that's synonymous. Extensive and normal mean the same thing. So normal metabolizers, it's fairly easy to keep them within the therapeutic window when you give them normal doses. So standard doses, standard response. most of us are normal metabolizers. There are two extremes or two opposite ends of this spectrum here. Some of us are slow metabolizers, some of us are fast metabolizers. So intermediate metabolizer, you can see here, that is think of that as a weakened form of an enzyme. And that tells us that at standard doses, you tend to have increased blood levels, increased at least temporarily above the therapeutic window. And the poor metabolizers usually means you have a non-functional enzyme. If you're a PM, you don't make the enzyme. And so it's very difficult to keep these people in the therapeutic window because they can have blood levels 2, 3, 4, 5, 20 times higher than the average person. On the other end, you have your rapid metabolizers and your ultra rapid metabolizers, and those are just two different types of fast metabolizers. And these are individuals who tend to be below the therapeutic window. Okay, so their blood levels are lower. You might consider dosing more aggressively in these individuals. Okay, remember this for a second because we're going to come back to this and we're going to map to this drug-drug interaction. So what we're looking at now is how you are born to metabolize medications. You know, all of us are born either normal metabolizers, intermediate, poor, rapid, or ultra rapid. And we can be any of those phenotypes for all of these different genes. So you can be rapid at 2B6, but slow at 1A2. So it gets complicated. Here is a chart, a real world chart to drive this all home. This is a chart of metoprolol. Now, metoprolol is particularly relevant in the geriatric population because it's the #1 prescribed beta blocker for hypertension, other heart conditions. Now, most of the world, if you give them metoprolol, they have an AUC to dose ratio of about 10. That's what you see right here, the normal metabolizers. Intermediates tend to be about 20, so twofold higher. Poors start approaching 40 AUC per dose. So a poor metabolizer can have 4 times the amount of metoprolol in their blood compared to a normal metabolizer. As you can imagine, these would be people more likely to have a lower heart rate or dizziness or some other significant side effects to metoprolol. Your options here are to decrease the dose or select a medication that does not go through that particular pathway. And we'll talk more about that later. So everything I've talked about up to this point is your genetics related to drug exposure. But we also need to keep in mind environmental factors that can affect your drug exposure also. And in a geriatric population where polypharmacy is extremely common, we need to take drug-drug interactions into account. So that is your environmental factor that you need to layer on top of this genetic information. And what I've mapped out here is the rough correlations between genetic predispositions and then environmental influences on drug exposure. So if you are a poor metabolizer, that's roughly equivalent to being on a strong inhibitor. Okay, so when we look at drug-drug interactions, we will call things strong inhibitors, moderate inhibitors, weak inhibitors, or non-inhibitor. Well, a strong inhibitor does the same thing to you that a poor metabolizer does. Okay, give you a real-world example. We'll go back to metoprolol. We use metoprolol as an example. If I was born a poor metabolizer, my blood levels of metoprolol are likely to be 3 to 4-fold higher than they are in the average person. If I'm a normal metabolizer, but I take metoprolol with paroxetine, or metoprolol with fluoxetine, or metoprolol with bupropion, I can see the same increase in blood levels, 2, 3, 4-fold increase in blood levels. Strong drug-drug interactions act the same way poor metabolizers do. Okay, so it's an environmental influence that has the same impact as a genetic influence. And if we map your genetic profiles to certain environmental profiles. PMs are strong, IMs are equivalent to moderate inhibition, rapid metabolizers are equivalent to moderate inducers, and then ultra rapid are equivalent to strong inducers. So drug-drug interactions. One drug can increase the blood levels of the other drug, or one drug can decrease the blood levels of another drug. If one drug increases blood levels, it's an inhibitor. If it decreases blood levels, it's an inducer. Okay. So this is really getting complicated now because our geriatric population tends to be on 4 drugs on average, 5 drugs on average. It's not uncommon to see Medicare patients on 10 medications, 20 medications. Just to quickly to show some real world examples of all of this. If you look at these time versus concentration curves, I want to show you the difference in exposure, the difference in blood levels when you take a minor inhibitor. So on the bottom is a minor inhibitor. You can see the difference between these two curves is not too dramatic. So minor inhibition doesn't have a really large impact on exposure. Moderate inhibition, which is on the top, you can see these curves start to separate a little bit. So moderate inhibition can cause some clinical effects. Look what happens with major inhibition. This is the combination of Strattera plus Wellbutrin. Okay, so this is the blood levels of atomoxetine if you add Wellbutrin to atomoxetine. So the white squares here are atomoxetine by itself. The black squares are atomoxetine when you give it with Wellbutrin. You see a 5-fold increase in atomoxetine blood levels when you add it to Wellbutrin. You're going to feel that. You will feel a 5-fold difference. So that's a major inhibitor. It's roughly equivalent to being a poor metabolizer. This can go in the opposite direction also. So if we have a drug-drug interaction and we are inducing an enzyme, we can lower blood levels significantly. In this case, we've lowered blood levels by 63%. Okay. All of these interactions tend to be additive. So if I have one inhibitor, I can increase blood levels by this much. If I have 2 inhibitors, I can increase blood levels even further. Okay, so all of these different interactions, all of these different genetic profiles are additive. And that's true with metabolism enzymes and absorption enzymes. Here is a chart of risperidone, okay, and the black circles right here are risperidone. The white squares that you see up here is risperidone in people who are intermediate metabolizers, so they're born intermediate metabolizers, and they have a PGP deficiency, okay? So these are individuals that are absorbing risperidone very rapidly, and they're metabolizing it slowly. So these are people who are filling the bathtub quickly, but draining the bathtub slowly. And as you would expect, you can see a significant increase in blood levels of risperidone. You would feel this difference. Okay, so just wanted to highlight the significance of these gene-drug interactions and these drug-drug interactions. And one of the questions we commonly get, well, what are the sources? What are the resources you use to develop these types of tests and to make some claims and recommendations that you make? Well, these are the primary sources here. Everyone's familiar with the FDA. What you may not be aware is that the FDA has hundreds of medications with pharmacogenetic guidance written right into the drug label. Citalopram is a great example. The recommendation is to not go above 10 milligrams of citalopram if you are a poor metabolizer. The risk of QT prolongation is elevated. CPIC, the Clinical Pharmacogenetics Implementation Consortium. This is an international group of researchers. They are the PGx experts. They are the world-renowned PGx experts, and they publish peer-reviewed guidelines, pharmacogenetic guidelines. One of the most recent guidelines, or actually 2 of the most recent guidelines, had to do with the pharmacogenetics of anti-inflammatory medications, things like ibuprofen, celecoxib, meloxicam, drugs that are extremely common in the geriatric population. There's a pharmacogenetic guideline for the majority of those anti-inflammatories. So CPIC has dozens of guidelines, and I'll show you why that's important in a minute. DPWG, think of this as the European equivalent of CPIC. And then there's PharmGKB, which is an NIH-sponsored database. It is a fantastic database. So I would recommend, put this on your desktop. Anything you ever wanted to know about drug-gene associations can be found in PharmGKB. So this is where we get most of our sourcing from. All right. Let's talk now specifically about geriatric pharmacology. What additional, we have enough to worry about with genetic parameters and drug-drug interactions. What else do we have to worry about in prescribing for older adults? And for the most part, it comes down to age-related pharmacokinetic changes, comes down to polypharmacy, and it comes down to comorbidities. Polypharmacy and comorbidities are sort of two sides to the same coin, because older adults are more likely to have multiple different health conditions. They're more likely to be on multiple different medications. Well, let's start with age-related PK changes right here. Okay, there's a lot going on this slide, but this slide, I hope, answers many of the questions we have about pharmacogenetics in an older population. So one of the most common questions is, does your intrinsic ability to metabolize medications decrease as you age? The answer is probably not. Okay, so what that means, there's many things that affect your ability to metabolize medications. Okay, it could be hepatic blood flow, it could be renal clearance, it could be your body's intrinsic ability for your CYP450s to work. It is probably not your intrinsic ability of your CYP450s to work, because most CYP450s do not decrease as you age. Okay, a couple of exceptions to that. CYP1A2, there is a minor decrease in CYP1A2 as you age. Now, the much more significant factor that influences CYP1A2 is smoking and coffee consumption. And that will have a much bigger impact on your ability to metabolize CYP1A2 drugs than aging will. Okay, so those are two things more important than the minor gradual decrease in your CYP1A2 capacity. CYP2C19 does moderately decrease as you age. Its intrinsic ability to metabolize decreases as you age. The funny thing about 2C19 is it peaks right around adolescence. So, kids hyper-metabolize something like escitalopram or sertraline. Their 2C19 maxes out at a relatively young age, and then it gradually decreases year by year by year. But it has, at best, it has a moderate impact. And your genotype has a far more significant impact on your ability to metabolize drugs than any age-related decline in these CYP450s do. Okay, so minor decrease in CYP1A2, it's probably not even clinically significant. Moderate decrease in 2C19. All of the other CYP450s are largely unchanged as you age. Okay, now this is surprising to a lot of people, but what it tells us is that your genetic profile has a bigger influence on your ability to metabolize medications than your age does. Environmental factors, drug-drug interactions, have a bigger influence on your ability to metabolize drugs than your age does. Okay, so that's CYP450. PGP is a different story. So I took some time earlier to make sure everyone understood PGP, because it appears that PGP does decline as you age, and this decline starts right around age 60. There's a school of thought that reduced PGP efficiency could be one of the things that contributes to dementia and Alzheimer's disease. We're not going to talk about that tonight. What we're going to talk about is the ability of your of drugs to more easily cross the blood-brain barrier because of PGP deficiency as you age. Okay, so starting around age 60, you start making, it's not clear whether you start making less PGP or your PGP just somehow becomes deficient, but it seems like you absorb medications more efficiently as you age because of the decline in PGP. Remember that PGP usually grabs medications and gets them out of your brain. As you age, you have less and less and less PGP, so those medications are not kicked out of the brain as efficiently. Increased absorption as you age. Why is that significant? Well, we'll talk in a moment about the Beers criteria. And the Beers criteria is a list of drugs that are potentially inappropriate in individuals older than 60. So drugs that, if given to older adults tend to be more sensitive to these medications. And what you'll find is that many of these drugs are psychoactive medications, drugs that need to get into the blood-brain barrier in order to be effective. Things like tricyclic antidepressants, things like SSRIs, things like benzodiazepines. All of these things are on the Beers criteria, and it may very well have to do with this PGP decline that starts around age 60. One of the reasons older adults might be more sensitive to these medications is because these medications are getting into the brain more efficiently. Now, remember, we talked about a genetic variant that affects PGP. Some people have a gene that results in decreased PGP. So you can imagine if you're born, if you're genetically born with this PGP deficiency, and you're 80 years old, where you've had 20 years of declining PGP, that you can be particularly sensitive to medications that are dependent on PGP. Just to give you some examples, again, paroxetine, escitalopram, certain tricyclic antidepressants, certain opioids, aripiprazole, olanzapine, all medications that are PGP sensitive. These may have more pronounced side effects in older adults because of this decline in PGP. So CYP450, we measure on our test. PGP, we assess that gene on our test. There's other things that influence your ability to metabolize medications as you age. Hepatic blood flow is a really big factor. That's not something we assess, but that does have a significant impact. And as you age, you have decreased hepatic blood flow. That probably has more of an impact on your ability to metabolize drugs than any intrinsic reduction that occurs as you age. Renal function, so GFR, that tends to decline as you age also. One of the things that's probably more interesting is this notion of frailty. So age in and of itself is not a very good marker of drug sensitivity. Okay, there's so much variability within older age groups, but frailty tends to be a better marker of drug sensitivity. And there's many ways you can measure frailty. They have a frailty index. They have an Edmonton Frail Scale, and these will measure or make an assessment of an individual's sort of frail state. But one of the things you tend to see in people that score high on this frailty scale is decreased muscle mass. And that results in a relative increase in fat. Okay, so the ratio of muscle to fat is decreased, and so fat stores are relatively higher. Many psychoactive substances are fat soluble, and so they will enter into fat tissue and exit fat tissue, and they can stick around your body longer if you have a particularly high fat to muscle ratio. So one of the other things we're concerned with older adults that are frail is that fat-soluble drugs, propranolol is a great example. Many of your tricyclics is another example. Diazepam is a fantastic example. Many of these fat-soluble drugs will stick around in fat tissue longer and have a more pronounced effect in individuals that rate high on this frailty scale. So age in and of itself is not a tremendously useful marker, but some of these other things are. Your genetic profile, understanding that PGP can decline, understanding that hepatic blood flow, renal blood flow can decline, and then frailty index tends to be a good marker. Okay, so that's intrinsic ability to metabolize medications or absorb medications as you age. But the probably biggest concern in the geriatric population is polypharmacy. We talked about multiple comorbidities. Here's some statistics that are really sort of eye-opening when it comes to the Medicare population, the 65 and older population. So 44% of men, 57% of women older than 65 take 5 or more medications per week on average. 12% of persons take 10 or more prescriptions per week. If you're on 10 or more prescriptions, you have a high likelihood of experiencing a drug-drug interaction. A patient taking 5 to 9 medications has a 50% probability of a significant drug-drug interaction. It approaches 100% when you're on 10 or more drugs. Almost 60% of older adults took at least one unnecessary medication. So this concept of deprescribing is a strong one. And then 35% of older adults experience an ADR, an adverse drug reaction each year. And almost 30% of these require hospitalization. Okay, so why am I saying all this? Because adverse drug reactions due to polypharmacy is a significant issue. And we generally don't have good tools built into our workflow to account for polypharmacy, to account for these multiple drug-drug interactions. I do this for a living. I do drug-drug interactions for a living, and it's too complicated to keep track of all of this polypharmacy going on. So one of the things we'll introduce you tonight is some software that we built to help you manage that. Going back to comorbidities, the other side of the coin when it comes to polypharmacy, what you're looking at here is a chart built from the FDA pharmacogenetic drug list. Okay, so there's hundreds of drugs that have pharmacogenetic guidance in the drug label. And what I want to highlight here is the different conditions that have pharmacogenetic guidance. The first thing I'll highlight is this large orange bar. The first bar, this large orange section that you see right here, is the psychiatric medication section. It is the largest bar that you see here for CYP2D6. So knowing someone's CYP2D6 genetic profile is rather important if you're going to prescribe psychiatric medications. Okay. Some of the other conditions, oncology is number 1, psychiatry, number 2, infectious disease, neurology, gastroenterology, cardiology. And as you can imagine, in a geriatric population, cardiology, oncology, that's going to be top of the heap right there. All right, here's a chart showing prescriptions written for a Medicare D cohort. This is going back to 2016, but this trend has not changed. If you look right in the middle and you look at the number of prescriptions written annually in 2016, 246 million cardiac drugs, 118 psychotherapeutic agents. It was the number 2 category was psych meds. Analgesics, antipyretics, the number 4 category. And then gastrointestinal drugs, anticonvulsants, anxiolytics, and sedatives, that rounded out the 6, 7, 8 profile here, or maybe it's 7, 8, 9 profile here. I highlighted these particular drugs because all of these classes of drugs have published pharmacogenetic guidelines to support them. So CPIC has guidelines for SSRIs, tricyclic antidepressants, analgesics, the opioids, and the NSAIDs have pharmacogenetic published guidelines. The proton pump inhibitors, Nexium, Prilosec, et cetera, all have pharmacogenetic guidelines. So here's millions and millions and millions of prescriptions that are written each year for the Medicare population for drugs that have published peer-reviewed pharmacogenetic guidelines that are recognized by the FDA. lastly, I want to talk a little bit about the Beers criteria. Okay, so the Beers criteria is a list that was developed by a doctor named Beers, but it has been adopted by the American Geriatric Society. And what it's intended to do is to identify potentially inappropriate medication use in older adults. Okay, and that is worded very precisely because what it is not is a list of contraindications for your geriatric patients. That's what it is not. It is meant to trigger a pause so that you can think about certain drugs a second longer for your geriatric patients. They've identified a list of drugs where geriatric patients tend to be more sensitive to them, largely for some of the reasons we described earlier. Okay, so many of these drugs are considered riskier in older adults, even before you know their PGx profile. So even before you know their pharmacogenetics, these drugs are considered risky. So these are drugs where you would want every piece of information available before you prescribe these drugs in the 65 plus crowd. And obviously knowing their PGx profile can shine a little light and give you a little more information to work with there. Okay. And ultimately the Beers criteria was developed to enable smarter prescribing in a population particularly at risk for polypharmacy, increased side effects, and comorbidities. And we talked about all that earlier. I do want to introduce you to some of the common medications that are found on the Beers list. Okay, so your tricyclic antidepressants, paroxetine, some of the other SSRIs are associated with fall risk in the older population. Hydroxyzine, your benzodiazepines, your proton pump inhibitors, your anti-inflammatories, your muscle relaxers, your opioids. These drugs, almost all of these drugs fall within the top 100 prescribed medications list. Okay, so these are very common medications. And the ones that I've highlighted with an asterisk right here also happen to have a CPIC guideline, so a published peer-reviewed pharmacogenetic guideline to support their use. Okay, so these are drugs that are inherently considered risky in a geriatric population, and they also include published pharmacogenetic guidelines. So it identifies drugs that you might want to consider doing some PGx testing for ahead of time. Okay, so this is how I feel sometimes trying to navigate all of these different types of interactions. It's complicated. We know that. We recognize that. And so we tried to build some tools to help clinicians navigate this sort of complex landscape here. Okay. And that's where we're going to take the next step to introduce you to some of these solutions that we've put together. First is our pharmacogenetic test. Okay, I imagine many of the people on this call have used our pharmacogenetic test. It's called Genomind Professional PGx. We often refer to it as GenMed Pro internally. It looks at 130 medications. It looks at 24 genes. And the goal is to provide information so you can have a more complete drug selection process and a more complete drug dosing process. Okay, so this is our report. It's it's 18 pages. It's a very thorough report, but we've decided to take this report and move it into the digital space. And so to take this PDF file, this static PDF file, and convert it into a more digital, user-friendly option. And that's what we have here with GenMed Pro. Okay, so GenMed Pro, you can find this on your laptop. You can use it on your iPad or wherever you want to use it. It is software that we built that helps make it a little easier to manage drug-drug, drug-gene, and drug environment interactions. Okay, so it's precision drug-gene environment interaction software. It addresses an entire list of medications. So, if the average geriatric patient is on 5 or more medications and 20% of them are on 10 or more medications, you can plug all of those medications into this tool and it will provide a composite assessment, an overall assessment of that drug profile. And I'll show you what this looks like in a minute. Okay. It includes psychiatric medications and non-psych medications because, these are polypharmacy patients. We can't look at their psych drugs in a vacuum. We have to see how all their medications are interfering with everything else. Okay, so I think we're going to, I'm going to pause here for a minute. I'm going to stop sharing and I'm going to pull up a demo of our GenMed Pro tool. So bear with me 1 second. Let's hope Zoom plays nicely here. And I will reshare my screen. Okay, someone from Genomind, just let me know that I'm sharing the Genomind portal.
Looks good, Dan.
Okay, thanks, Heather. So if you are currently using Genomind, you are familiar with the clinician portal. This is your landing page right here. So what you would do is go to your results. If you had multiple offices, you would just pick an office. We'll pick the King of Prussia office. And then you'd have a list of patients here. These are not real patients. These are patients we invented. But we're going to pick a patient called Jenny Medcheck right here. Okay, clever name, right? This will bring you to Jenny's profile. You could always view her pharmacogenetic report right from here. But you also get immediate access to this GenMed Pro software. And what this software does is it takes their genetic profile and it will marry it to any drugs that you enter into this. So it's a way to test drive different medications to identify significant or serious interactions. So if you're looking at this person's genetic profile, you can see that they happen to be a 2D6 poor metabolizer. They happen to be positive for HLA-B. They happen to be intermediate at UGT2B15. And all the other genes look pretty good right here. So we'll wrap that back up and we'll enter some medications. We'll just test drive some different medications here. So we'll start with paroxetine, okay? We decide to give Jenny paroxetine. We run it through GenMed Pro and it says, uh-oh, there's some type of high-risk interaction here. And the arrow is a prediction of blood levels. So we expect an increase in blood levels here, an increase in exposure. And then the icon is an estimate of the magnitude of that risk. So it can be high risk, moderate risk, or low risk, or no risk. In this case, this is a high risk interaction. You can see serum levels that are 2 to 3-fold higher in this individual. And what's driving that, the causal factor is 2D6 poor metabolizer status. So you may be saying to yourself, well, what do I do about that? The PGx guidance tab is a list of all published peer-reviewed guidelines or FDA guidelines for this medication. And so if we click that tab, we will see that CPIC has a guideline, and it's pretty clear what to do here. Select an alternative drug that does not go through 2D6, or consider a 50% dose reduction of paroxetine. Well, you can't get much clearer than that. Okay, that is a nice, clean, crisp pharmacogenetic guideline. Pick a different drug. If I really am in love with paroxetine, just decrease your starting dose by 50%. Okay, so we will have CPIC guidelines, FDA guidelines, or DPWG guidelines. Okay, let's say you wanted to change paroxetine, right? You looked at the guideline, it said select alternative drug, and you're saying to yourself, well, I don't know what goes through 2D6 and what doesn't. You can click this alternative medications tab, and it will generate a list of similar medications, and it will rank them for you by their risk, their genetic risk. Okay, so this is an individual where if I wanted to pick a different SSRI, I probably would not pick fluvoxamine. It has a similar risk. I probably would not pick fluoxetine. It has a moderate risk, whereas citalopram, escitalopram, and sertraline have no gene-drug interactions here. So if I made the simple change of sertraline for paroxetine, I have minimized a potential risk factor. Remember that paroxetine was one of the medications on the Beers list. So this would have been an individual, over 65. You give them paroxetine, it's a risky drug to begin with, and they're a poor metabolizer, so they were likely to have elevated blood levels, and paroxetine is a PGP substrate, so they may have had increased absorption of paroxetine. So all of these different parameters are taken into account when you plug them into this tool here. Okay. Like I said earlier, it is not just psych medications. It's also blood pressure medications, migraine medications, cholesterol medications. The 96% of the most commonly prescribed medications can be found in here. Here is Toprol, a beta blocker. You run into the same risk here with Toprol. The guidance from DPWG says do not prescribe more than 25% of the standard dose. I would be more inclined to switch out to a different medication. So how about I just pick a Tenolol here? And that looks like a cleaner medication profile. I've now just minimized two potentially risky drug-gene-drug interactions. Another thing with the alternative medications, you can also select multiple different categories of medications. All right, maybe sertraline is a better representation here. So if you wanted to select an SNRI or maybe a non-SSRI antidepressant, you can just hit the update button and it will rank those different classes of antidepressants for you also. So, I probably don't want to use venlafaxine, vortioxetine, amitriptyline in this individual. But bupropion looks pretty good. Desvenlafaxine looks pretty good. So it assesses all these multiple parameters. Okay. Going to look at a different patient here just to show you a couple more parameters. Here's Chloe Pitigrel here. You can see that Chloe has a CYP1A2 enzyme, a 2C19 enzyme, and a 2C9 enzyme. We have her on Cymbalta, and it looks pretty good. But what if she was a smoker? We click the smoking button right here, and you see that changes your outcome there. We expect decreased blood levels of Cymbalta here in Chloe, and that's a moderate interaction, okay? It's a gene-drug environment interaction that tells us we might need to increase our Cymbalta dose in the context of smoking because this is someone with lower blood levels, okay? I'll get rid of Cymbalta here for a minute. I'll get rid of smoking. Let's enter a drug called Plavix. Now, Plavix, there are millions of prescriptions of Plavix. It's also known as clopidogrel. It's an antiplatelet medication, a blood thinner. There's millions of doses of these prescribed every year. But this is an individual that has a genotype where Plavix is less likely to be effective. In fact, the guideline says alternative antiplatelet therapy recommended, specifically prasugrel and ticagrelol. So alternative medications, you can find those alternatives here, you replace them, and you have minimized a drug-drug interaction right here. Last thing I want to show everyone, if you look at a patient profile, all your patients would be listed in your patient landing page. If you enter medications on the requisition form, if you enter your patient's current medications on the digital requisition form, we will pre-populate GenMed with those medications, and we'll run a check in the background. So by the time you get to the portal, you can look and find out which patients have significant drug-drug interactions. So in this case, I see Zach Morris here has a pretty ominous looking icon there. I can click Zach's profile. I see Prozac is interacting with his codeine. What is a cleaner? Let's see if I swap out with escitalopram. I've now minimized drug-drug interactions there. So we'll do a pre-check to help you identify your patients that are on high risk, moderate risk, or low or no risk interactions. Okay. I'm going to try to pull up my PowerPoint slide here. And I think I'm sharing it. Heather, do I have this slide shared right now?
Yes, you do.
Okay. So just the last thing we want to talk about before we open it up for Q&A is the current Medicare coverage policy. So a few months back, Medicare announced an LCD, a local coverage determination. And if you want to look into it yourself, the name of that LCD is L38294, but basically stated that in certain circumstances, Medicare recognizes that pharmacogenetic testing can reduce risk, and Medicare will pay for pharmacogenetic testing. Now, these are some actual, copy and pastes from the LCD, but I've highlighted some important parts here. So pharmacogenetic testing to improve safety and the use of specific medications by avoiding potentially harmful medications, doses, adverse reactions known to occur with certain genotypes. Okay. My initial question was, well, what genotypes? And they were nice enough to define that later on, as defined by the FDA or CPIC, categories A or B. So one of the reasons I originally introduced you to that FDA table of biomarkers and to CPIC earlier is because those are the sources that Medicare is using also to identify payable gene-drug interactions. Now, there are hundreds of gene-drug interactions that would be considered payable. So SSRIs, SNRIs, very sensitive to CYP2D6, CYP2C19. Opioids, many of them are sensitive to 2D6. All of your tricyclic antidepressants are sensitive to 2D6. Many of your mood stabilizers can be sensitive to HLA. So there are hundreds of drug gene pairs that Medicare has identified with this coverage policy. It's very exciting. It opens up pharmacogenetics to a whole entire population that really didn't have access to it before. And so I want to make everyone aware that pharmacogenetic testing is covered for geriatric population when certain criteria is met. In most cases, in a geriatric population where people are on 5, 6, 7 drugs, most Medicare recipients would be eligible for coverage for this type of testing if they're on some of these common medications. So that concludes our formal presentation for the night. I will open it up to Q&A. There is a Q&A box at the bottom of your screen, so feel free to add some questions in there. We also have on the call 2 members of our medical affairs team, Dr. Tori Hoffman and Dr. Seema Patel, who have been answering questions in the background as I've been presenting, but they're here to help answer questions as well. So I'm going to look in the Q&A section, see what we have in here for now. Nothing currently, but I'm going to look into some of the previously answered questions and see if they're good topics for the entire audience here. Effect of aging on liver metabolism. I think hopefully I discussed that appropriately. So there's a question here about the APOE gene, which is the Alzheimer's risk gene. That is not something we include in our pharmacogenetic panel. So there's a difference between using genetics as a diagnostic tool versus using genetics as a prognostic tool, which is what pharmacogenetics does. So we don't test for the ApoE4 gene. We've had some prior products on the market that did test for that, but our current pharmacogenetic product does not test for ApoE. Okay, looks like we have some new questions in here. Okay, so Heather, this might be a question for you. So it's a question about identifying Medicare patients. So let me read the question specifically. Does Genomind help clients verify whether Medicare will pay in their situation? I'll give my answer, and then Heather, you can tack on to that. So we try to identify if a patient's, we would always ask for a patient's medication profile ahead of time, or we would ask a provider, what medications are you considering for this patient? And if we know that ahead of time, we can tell you whether or not that patient meets the criteria for Medicare reimbursements. Heather, anything I should add to that?
Yeah, no, that's correct. Everything would be verified up front. And if the patient were to have any kind of out of pocket, that would certainly be shared prior to accessioning the sample.
Okay, good. Thank you. So I get these billing questions right once in a while. A question about will the slides be available? The answer to that is yes, they will be available. You will receive an email either tonight or tomorrow, and there'll be a link to these slides. So yes, they will be available. Also, you will be asked to rate your speaker tonight. So that's me. It's a survey that we ask you to fill out. It literally takes 60 seconds to complete the survey, which we try to get as much feedback as we can to try to improve these virtual webinars. So I ask that you take 60 seconds just to complete the survey. Okay, let's see. Any cases with PGx profiles along with medication profiles and medical comorbidity that would suggest consideration of ECT? So medical comorbidity, I don't know about that. Obviously, level of severity of depression, but the only gene that has been associated with ECT response is the COMT gene, the COMT genotype. You can actually send me an email and I can send you the meta-analysis. So my email is ddowd@genomind.com, ddowd@genomind.com. So there was a meta-analysis a couple of years back looking at the COMT-val-val genotype and how that influenced response to ECT. And the conclusion was that there was a better response to ECT treatments and greater tolerability to ECT treatments in the COMT-val-val individuals. So if you're interested in learning more about that, it looks like one of our MSLs may be answering your question directly to you, but feel free to email me, ddowd@genomind.com. I will send you the meta-analysis that supports COMT-val-val association with ECT. Okay, I think we have time for a couple of more questions. Looks like my MSL team is busy has been busy answering most of these questions in the background. So thank you to them. I forgot to mention Dr. Gabriella Williams earlier also, but it sounds like she's on our webinar as well. Our medical affairs team is fantastic, by the way. If you do genetic testing with us, you have access to a team of PharmDs and PhDs. We're happy to walk you through the report or to supply you with literature to become more educated about these associations. Okay, doesn't look like there's any more questions in the inbox. I'll hang tight for another minute here to see if there's any last minute questions. And if not, I appreciate everyone's time and attention. Okay, so it looks like this question has to do with the recent publication, pharmacogenetic testing in adolescents. So yeah, there was I think it was published this week or last week. It was a failed trial of pharmacogenetics in an adolescent population. I think the total number of individuals was 160 or something along those lines. It was not our test. It was a competitor's panel that was used. It was a failed trial. We're going to dig into this and probably make a statement on this. One of the things you tend to see with when you do these RCTs with pharmacogenetics, and we discovered this with one of our previous trials, is that not every clinician follows the recommendations that are in the report. And what we found with our RCT, now this was an adult population, but what we found with RCT is that the clinicians that actually followed the recommendations of the report had about a twofold increased remission rate when they actually followed the instructions. So I can't speculate as to if that happened in this trial. We're going to dig into that. We just came across it a couple of days ago. So we're going to dig a little deeper into that trial. And see if we can identify some of the reasons why this might have been a failed trial. But if you want to email me.
Dan,
Yes.
if I could chime in the paper, they said that one of the things that they needed to do was to look at the treatments that were assigned compared to what the report said. And so they've done that sort of congruency analysis, which is exactly what you referenced that we did in our trial, in which we showed that remission was twice as likely in patients with depression whose treatment was congruent with the assay results.
Thanks, David. So that was Dr. David Kraus. He's our Chief Medical Officer. Sounds like David's had more time to dig into this trial than I have. So thanks for the support, David. Okay. So we have a question here. It's more of a logistical question, so I'm not going to open it up to the broader audience. Denise, feel free to contact customer service for that question, and or email me, and I'll connect you with the appropriate person. So that looks like the end of our questions. So thanks everyone for your attention and time tonight. And nope, we still don't have any questions. So thanks. That concludes the presentation tonight. Have a good night. Thanks for your time. Bye-bye.